The obesity paradox describes the observation that, at times, people with obesity have better health outcomes than people without obesity. This is considered a paradox because it goes against the common notion that obesity should lead to worse health outcomes, not better. This has been observed in several different areas of health in a large number of studies, and I've even mentioned it in 2 prior videos. However, its existence is still debated in many contexts, and research on this topic is ongoing. So what does this large body of research suggest? That is what we will explore in this video. First, as a quick refresher, we are defining obesity by BMI measurements, where your BMI is defined as your weight in kilograms divided by your height in meters squared. You can see various classifications for overweight and obesity on my right. The lower thresholds are often used in Asian cohorts. Many studies have demonstrated the obesity paradox. For example, one study looked at Mexican Americans aged 75 years and older, finding the greatest longevity in those with overweight and class 1 obesity. Another study looked at Polish seniors and found some differences based on age, but in general, better outcomes in the overweight and class 1 obesity categories based on the Kaplan-Meier survival curves you can see on the screen, as well as the multivariable analysis they performed. An Asian cohort analysis regarding survival after excision of lung adenocarcinoma found that people in the obesity range by BMI had the best odds of survival. When looking at other health aspects, such as measurements of physical performance and cognitive ability, one study of elderly individuals in Turkey found optimal results at a BMI of 31 to 32 in females and 27 to 28 in males. There are more examples than just these, but the main point is that for a variety of different populations and health conditions, this obesity paradox has been found. However, not everyone believes that this really exists. Let's discuss some of the caveats that have been brought up to potentially explain the obesity paradox. One reason the obesity paradox may exist is because people lose height as they age. With the same weight but a lower height, your BMI will increase, and thus, if you were previously in the normal weight category and generally healthy, near the end of your life you may move into a higher BMI category just from the height loss itself. A 1999 review article examined data from studies looking at this in people aged 30 to 80 years old, finding the BMI increase from height loss with age is on average 1.2 for men and 1.6 for women. While not entirely negligible, this is not that big of a shift overall, and this likely only accounts for a small degree of the obesity paradox. A second consideration that has been observed is that individuals with obesity often develop chronic illnesses such as cardiovascular disease at a younger age. This can lead to earlier utilization of healthcare resources and result in beneficial changes to dietary and exercising habits, along with medication use that collectively can extend their lifespan. This likely does explain some of the obesity paradox. A third consideration is the possibility of bias in the datasets, particularly collider stratification bias and general selection bias. This was elegantly demonstrated in a correspondence to the prior study I showed. The argument goes like this. It is well documented that obesity contributes to cardiovascular disease. People without obesity but who go on to develop cardiovascular disease are more likely to have underlying genetic factors that contribute to their heart conditions, and these genetic contributions may lead to a higher risk of death than obesity alone. Alternatively, when looking at people with obesity who do not go on to develop cardiovascular disease, these individuals may have protective genetic factors that decrease their overall risk of death. Either way, the stratification by cardiovascular disease status leads to an inverse correlation between obesity status and less fortunate genetic status. Thus, even if obesity does increase the risk of cardiovascular disease and mortality, when looking at the data stratified by cardiovascular disease status, it will appear that obesity is protective. This same argument can be applied to many other health scenarios and likely accounts for the obesity paradox to some extent. A fourth consideration is the possibility of reverse causality. For example, smoking is associated with an increased risk of death and a decreased risk of having obesity, so including people who smoke in the analysis may make it seem like having a normal range BMI is associated with an increased risk of death. The same argument can apply to pre-existing conditions, such as cancer and cardiovascular disease that lead to weight loss. Several studies evaluating this have found the obesity paradox significantly diminishes or fully disappears when excluding individuals who smoke or who have pre-existing conditions. You can see this in one data set on the screen. Here, no obesity paradox was seen in people with heart failure without comorbidities, where all the survival curves are quite similar. On the other hand, when looking at the more elderly individuals and those with comorbidities, being in the overweight and obesity range initially seemed helpful. However, when performing a multivariable analysis to help control for illness severity, there was no advantage of having obesity compared to normal weight. Therefore, in this example, obesity is simply a marker of less advanced disease and thus correlates with longer survival rather than contributes to longer survival. This can explain the obesity paradox in many cases. A fifth consideration is whether underlying body composition plays a role. I previously showed one review that demonstrated having increased levels of fat mass is associated with increased mortality risk, while having increased levels of fat-free mass is associated with decreased mortality risk. I also previously showed data from one cohort analysis finding that when you adjust the BMI for muscle mass, the risk of mortality increases as BMI increases, and when you further adjust for waist circumference, this excess risk disappears. This implies that an increased level of muscle mass is protective against mortality, while an increased level of abdominal obesity is harmful. Other studies support these findings. One study found that genetically predisposed levels of fat mass were directly correlated with increased mortality risk, and that when measuring actual body fat, this was also seen in people with healthier lifestyles. A separate study evaluating predominantly white males around age 60 years found that those with the highest levels of skeletal muscle had twice the odds of reaching age 90 years, while those with the highest levels of body fat had less than half the odds of reaching age 90 years. A systematic review and meta-analysis found that in older adults with an elevated BMI, the risk of mortality was increased in individuals with a lower appendicular skeletal muscle mass index, which is a measurement that describes the muscle mass of the limbs in relation to the height. A separate review found that the obesity paradox was mitigated in individuals with chronic heart failure and chronic obstructive pulmonary disease when restricting the analysis to people with good cardiorespiratory fitness, implying when looking at only individuals who have higher physical performance capacity that obesity is harmful. However, not all data supports a harmful role of fat. For example, one study found that in people with heart failure, having a higher fat mass was protective against cardiac events, while having a higher lean body mass made no difference. This brings up the interesting question of whether there is a biological benefit to increased levels of body fat, at least in some scenarios. Indeed, there are actually several medical conditions where having obesity may prove beneficial in some ways. One example is cancer. While obesity is associated with an increased risk of several types of cancer and can diminish the effectiveness of certain types of treatment, it is also associated with decreased chemotherapy-associated toxicities, improved response to chemoradiotherapy in certain cancer types, and enhanced efficacy with certain types of immunotherapy. This latter finding is thought to result from obesity being a pro-inflammatory state, which may prove helpful when you want to use the immune system against a tumor. Another example is critical illness in an ICU setting, where obesity seems beneficial. Part of this may be due to confounding factors, as people with obesity may be admitted to the ICU earlier in the illness course, but there are several proposed mechanisms for why obesity may be helpful, which I've listed on the screen. I'll emphasize the first one I listed, which is increased nutritional reserve. One of the primary functions of body fat is to store energy, and for many medical conditions where there is a decreased appetite or decreased ability to consume food, having additional body fat can act as a buffer against poor nutritional status. Another disease where obesity may prove useful is chronic heart failure, and I've listed reasons for this on the screen as well. Here, I will emphasize that in obesity, the adipose tissue, which is your body fat, can become hypoxic and pro-inflammatory. Hypoxia means there is a lack of oxygen, and the body can try to counteract this by promoting anti-inflammatory and pro-vascular mechanisms. These mechanisms can assist with heart failure treatment. There are potential benefits for other medical conditions as well, though these are less well described than the ones I mentioned previously. The overall point is that while obesity can contribute to developing many medical conditions, once you have some of these conditions, obesity may help protect you from suffering more severe complications from them. In summary, there are many potential explanations for why the obesity paradox is found, but it also seems plausible that obesity is helpful in specific contexts. Given the numerous caveats that have been brought up, as well as how this varies with specific medical conditions, it is not surprising this is an ongoing area of research with active debate. As the obesity paradox is more commonly discussed with respect to elderly individuals, this brings up the question of whether elderly people with obesity should lose weight. This topic deserves its own video, but when done appropriately, weight loss can likely be done safely and yield several benefits for health-related quality of life, as well as various obesity-related comorbidities when present. If you're not sure what you should do for your own specific health and medical situation, then I suggest discussing this with your healthcare provider. With that, I thank you all for your time, and maybe I'll see you around for the next video. Goodbye.